program tonight, and thank you all for joining us. I'll just like to welcome our guests tonight. We've just had Zakur talking to us. Zakur did a wonderful job with our opening ceremony for this first virtual international Wonka World Rural Health Conference, the 17th World Rural Health Conference. This is the first of our series of lectures, and I'm very proud that these lectures are in partnership with Nick Torres's group, the Network Towards Unity for Health. I'm Bruce Chater. I'm the chair of Rural Wonka, the rural group within the World Organization of Family Doctors. And this is our first of a series of lectures that go with our conference. And we had, for those of you who haven't been able to see the opening ceremony, I think it was just a wonderful time that we had together, seeing Bangladesh and seeing the way they're going in Bangladesh, very much in the style of what we're talking tonight about pathways. The task force is actually co-chaired by myself, Roger Strasser from who's the founding chair of Rural Wonka, is now in New Zealand. Pratush Kumar, who's the secretary of Rural Wonka, and Allendo Avelino, who's a public health physician in Brazil and a member of Towards Unity for Health. Nick was asking about CME. We have this whole series accredited through the Australian College of Rural and Remote Medicine, and I'll be replying to anyone who needs to have further details of that along the way. We've got a number of lectures tonight, and I think I don't want to hold us up. We're going to have one lecture from me. I recorded this as the very first one of this series, and then one by Jim Rourke, a case study by Jim Rourke, a case study by Farah Neuer, who I've noticed is on now. Another one by Saad Yukes from Morocco, and then Tom Kankan from India. So we're very, very pleased to have those case studies. As I said, if you could have your microphone to mute. At the end of this, we will have some discussion. I would encourage you to put any comments you'd like on chat along the way, and they can be answered as we go. The lecture and the case studies on this occasion are a little bit longer, so it will leave us some limited time, but I do hope that at the end, when we've got the attendance list from this, we'll be able to use that attendance list to get back to you and be able to start some discussion online about this really important topic. So Nick, if you'd like to just say a few words.
I'll just say a quick welcome from the Network Towards Unity for Health. We're excited about this partnership. I will just go with the video. Thanks, Bruce.
Hello, I'm Bruce Chater. I'm the chair of the Wonka Working Party on Rural Practice, and I'm very delighted to be the first of our new series between the Network Towards Unity for Health and Wonka Rural in talking about the things that are really important in rural areas. A key one for us is rural training pathways and pipelines, and the type of pathway or pipeline depends a little bit on your attitude. For people in that sequence, going from possibly a childhood in rural areas over to service in rural areas in one of the health professions, hopefully seems like a pathway. It's a natural way of going from your aspirations through to service. For many administrators, obviously, it seems like a pipeline that you can put graduates in one end and out the other end. You'll get, in this case, a rural generalist in my state of Queensland, where Australia, where they serve in rural areas. So both of those have their benefits, but I'd like to talk today particularly about a stream concept, really, about how we stream people. We don't want to force them up a pipe, but equally we need to have some way of making sure that we get people from one end to the other, from the very start, might be in a rural area, might be in an urban university, right through to rural service. The lessons we've learned as a doctor organisation go back over 40 years of research into rural pipelines. Over recent times, we've been doing some work with WHO, looking at not only in medicine, but also in other professions. The emphasis too in the past has been on developed countries, but equally many of the lessons we found are equally applicable to low and middle income countries. So hopefully the lessons that I share with you today will be applicable in your circumstances, be they low and middle income or highly developed, be it in medicine or other professions. So I want to start with looking at the various elements of the process, right through from inspiring students to go into rural practice, right through to sustaining that at the end. So let's start off with the inspiration. It's terribly important, I think, to make sure that students who want to go into the health professions in rural areas are able to have a taste for it, really. We need to give them an ability to understand what rural service, rural practice in a profession might be in their future. Rural people often have a lower educational level, but often, well, always, they're just as smart. I think often that lower educational level is taken as they're not quite as intelligent. But I live in a rural area. I'm a rural doctor in Australia, and I can tell you they're pretty smart and a lot smarter than me in some aspects. In inspiring people, we need to grow our own. We need to get the local people up and into the professions that we want. They've got rural comfort. They know what rural is like, and they are not afraid of rural areas. But we need to open their eyes to role models and quality practice. We need to let them understand that they really can provide a wonderful service in rural areas. We need to inspire them and expose them to that. We need to mentor students in rural areas, and it's a bit like we say, it's like a bit like old growth forest. It's there to shade the ones that are coming through, and we need to make sure that they are able to grow in that shade. So we need enough mentors and enough support to be able to do that. We need to show them how to get there. We need line of sight right through to their future career. Everyone knows through the movies and TV how to get to be an ER doctor, how to get to be a orthopedic surgeon, but there's not that line of sight about being a rural practitioner of any sort. So I think we need that. We've had some series on radio and TV that have kind of shown some of that, but probably not particularly accurately at times. We need community support. Jisha University in Japan actually supports from the prefectures doctors to go into training, and equally I think we need to provide those supports through scholarships and other mechanisms. We need apprenticeships where people can grow up into the professions, and the step ladder approach that Zamboanga in the Philippines uses, where you can work through from community health worker, nurse, doctor, is a wonderful way of following things to a future career in rural. So let's go from the inspiration then to selection. So when we want to select students, we need to look at how we select the right people. We need to select them by the area that we want them to work in. I think that's particularly important. Paul Worley, our Rural Health Commissioner in Australia, says that people tend to go back to country. And so I think having a preference for those is important, and supporting them in that way. We need to look at what their preferences are, and we need to be able to address those. We need to select by rural background more generally, but also by rural experience. We've found in the research we've done that people who have had successful jobs in rural areas do well in rural health. So we've got a student who comes and visits us, who's been in charge of a cattle feedlot in the past. And then decided that he loved rural, but he wanted to give more to rural communities. So that rural experience can be more important than anything else in driving people to be successful rural professionals. So selecting by intent, that can be hard. People want to get into medical school, want to get into nursing school, want to get into other professions, and trying to pick out whether the intent is real is something there. But I think it can be done. Selecting by community by community, looking at trying to get those people from community back into the community. As I said before, the stepladder approach, bridging training for some, not quite a stepladder, but also getting people the extra skills that they need. And don't forget lateral entry, because there are people who change their mind, and I'll talk a little bit more about that in a moment. So we've done inspiration and selection, and now as students particularly, we need to look at immersion. So we need to immerse them into rural practice and in the rural context. There's no good expecting that you can teach people in an urban setting the rural context. You really need to give them that exposure, because the decision making is quite different in rural. Limited resources, you've got to use this resource quite often instead of putting someone straight into a CT scan. So it's about giving people the right skills to know whether to treat locally or transfer, and to have the confidence and the bravery, in fact, to be able to deal with things in rural areas. So you need to educate them in the area you want them to go to. You need to support the students in those areas. They need to feel part of the team, part of the community. You need to contextualize the curriculum. So it goes on that what I was saying at the start about rural context. We need to make sure that the curriculum really does deliver the skills that we need for those people in that area. We need to value local expertise. The experts are here in the consulting rooms. They're not in the academic centres. I'm an academic as well. I'm the Professor of Rural and Remote Medicine at the University of Queensland. But quite unashamedly, I sit in a rural area, and that's what we need to see. We need to grow academic staff in those areas. And recognise that the education in rural needs to be at the front line. The front line are the teachers. We need to support them. We need to value them. We need to pay them. We need to make sure that we spread the support for academia across from the larger centres into the smaller centres. They're the role models. And we need to make sure that those role models are supported. We need longitudinal placements, and there's been heavy emphasis on that over recent years, exposing students to longer times in rural areas. But also we need repeated small placements. I think we need the opportunities for students to go out with student clubs, to spend as they do in our discipline of rural and remote medicine here in Queensland. They spend 6 weeks in a rural area. They're not at the moment during this COVID time. They're actually doing it by video link at the moment for a short time, but we hope to have them back. But those repeated placements are really important. They're what I call the convertibles. They're the ones who get inspired by being able to see that medicine, nursing, and other areas, community practice, are all possible in rural areas at a high quality. And we need to build attachment to an identity to community and their needs. So we need students to actually be immersed in that and that understanding. So let's go on now from student time right through now to the vocational training time. So, and that's different in different professions. So, and I'll unashamedly talk a little bit about the medical side of things, but I think a lot of that's very applicable in how we prepare students for that next step, which is into their vocational training. So for doctors, nurses, community and other health workers, we need to once again keep preparing for rural in rural. So that's especially important to continue that process. They need to be generalists. So they need to be broad, but also tailored for the communities that they're in. So having a broad range of skills, being the Leonardo da Vinci, being the person that can do a wide variety of things is important in rural areas. Specialisation just doesn't work in rural areas. You need that broad set of skills. And equally, they need to be full scope. So it's not only breadth but depth, and so doctors in those areas need to be able to do primary and secondary care, public health and curative medicine. So, and the same for all. Nurses need to be at full scope, community health workers need to be at full scope. So we need recognitions and qualifications in the area of family medicine, which is our area of expertise. We need full scope family medicine, including secondary care. And in Australia, that's called a rural generalist. I know generalism means different things to different people, and sometimes generalism means you don't have any qualifications. In this, it's the ultimate qualification of being able to do full scope practice. Prepare people, but not for too long. Sometimes you actually find people get more, future health professionals get more and more unsettled in highly specialised settings because they're seeing the very toughest and worst parts of it, and sometimes becoming more dependent on the specialised settings. So we need to avoid taking that for too long. We need team training, but especially with local teams. And as I said, once again, in the context of the local situation. Vertical integration is important. And in our case, making sure that we've got the doctors, the registrars, the interns, the students working vertically integrated and be able to share the experience, obviously laterally integrated as well in teams of generalists. You need to end the training in rural. There's no point in kind of having that last term in a specialised centre because people will tend to settle there. So trying to aim to have the training end in a rural area. Often people in their training will, with their spouse and family, look at a particular site they might like to be in. That should be encouraged. And what we need to do is tailor the training to the desired location so that they might need extra skills in mental health or obstetrics or anaesthetics. We need to allow lateral entry. So as people are going through and find that they didn't want to become a surgeon or didn't want to become a particularly specialised nurse, that they can take those skills. We've got a nurse here who's come back to the bush after doing intensive care, and that ability to take those skills to a rural area is really important. We need to include and guide telehealth implementation. Telehealth can be a double-edged sword, and properly done can really support rural areas. And we need to prepare for lifelong learning. So this is the vocational training situation that we need to put together. So we've now prepared them and we've taken them out to rural areas. And this is often where things can fall down if it's not prepared properly. We need to satisfy them. We need a satisfying career in rural areas. And so that involves a couple of things. We often talk about work-life balance, but this is, I think the important part there is about the life. It needs to be a desirable community. And the communities need to be engaged to do that. And it is a social contract. The health worker looks after the community, but equally it's important that the community understands to look after the health worker. If that social contract doesn't happen, then we lose health workers. So accommodation's important, including the little things. When I was in India after our conference there, I went out into the bush and just little things like around the accommodation, there were, in one of the spots I went to, there were no trees. So there was no area for people to sit under in the hot summertime. There's no area for people to socialise and congregate under. So having those little things can be really important. The spouse determines everything quite often, and unless the spouse is supported, preferably with employment, satisfaction in other ways, then there's an old saying, happy wife, happy life, and it happens the other way too. Unless the spouse is supported, we're not going to keep people in rural areas. Education for children is sometimes an issue, and I think we recognise these days, well, it's always been the case really, that not every health worker in rural areas will stay there all their life. It might be that they need to move to another area for their children's education, and we expect that might happen. Need to allow flexibility, part-time work, livable rosters and those sort of things. We need cultural competence both ways. It's often emphasised that doctors need to be able to understand the culture that they go into, and that's terribly, terribly important. Same with all other health professionals. That's why coming from those areas, people are ahead. But it has to work both ways too, and we need to educate the community sometimes about what doctors do so that they can understand a little bit more of that. We need adequate remunerations, often either over or under emphasised. It's just an important part about it. And one of the things that made the Rural Generalist program work so well in Australia was that the rural doctors were paid the same as specialists in the city were paid. So having that equity is important. So that with that comes recognition and being valued, and we need rural doctors to be seen as something that is an aspiration. Rural nurses should be an aspiration. Rural Aboriginal health workers or community workers should be an aspiration for people. We need safety, and that's particularly important in many areas of rural, and basic sanitation in some of those areas too. We need satisfying work. So it's no good having doctors and others and nurses sent out into a workplace where they can't do anything. So we need a can-do culture. We need that clinical bravery for people to get in and do things for their community, and they need to be supported in that by colleagues. We need hospitals that work. We need primary care that works. So, and doctors, nurses, allied health workers, community workers are all very innovative in rural areas, but that can be crushed by just being unable to have the resources or the backup. Teamwork with support and backup is really important. Integration is a great strength of rural, but it needs to be encouraged, and it can easily break down. Good rosters are important. I think one of the things I've learned, I was originally a single doctor in this town, and I've learnt that there should never be a single one of anything in a community. We need at least 2 full-time equivalents to make 1 health worker, because they need time off to avoid burnout. You need to support them like they do in the city. They need to be a teacher and supported for that. They need support staff such as an intern. They need point of care technology and IT. And we need local upskilling so that the teams are really drilled properly and that they know what they can do and how they can do it well. So they need to develop that confidence, and the best way of doing that is drills. So I've gone through getting them to there. How do we sustain it that little bit further? So sustaining this is really important, and that's one of the big issues sometimes, is trying to keep it happening. I think we need to recognise that we need quality infrastructure. We need to make sure that we've got quality practice happening, and that's quite possible in rural areas, but it needs to be supported and it needs to be recognised, and in fact needs to be shown by audit and other things. And we need the workforce, as I've talked right through this about. So being a teacher actually helps to keep people in rural areas. There's a number of studies that show the benefit of being a teacher and how it satisfies people to hand on their skills. Teamwork helps too. If everyone's fragmented, it's not going to help. We need an engaged community, that community that looks after the health professional while the health professional looks after the community. Need to respond to community needs, particularly and practically address community needs. So we need that once again, that alliance between the health professional and the community, and we need to identify community opportunities. We need financial viability, and we need to develop services to assist community viability. It's well known that health workers mean that people can be more productive, that they can stay in their community, and that adds to the richness and the sustainability of that community. So what's against us? The urban draw is an issue, and we need to recognise that. And many of the factors in urban draw are the ones I've just talked about. It's very easy for city hospital to mean an empty stream, where the stream that is going to rural is completely dried up. And so we're looking at trying to even out the things that are city draw, and that's about remuneration, about facilities, about support, about status, about opportunity. There is a flow back to home country, and so we always say we try and get the students out to rural areas for long enough that they develop a partner in a rural area who might like to go to rural as well. So the partner origin, the origin of the health professional can be important. There are role models in the city. There need to be good role models in rural areas, and there is a bit of fear of missing out sometimes, particularly in people who've spent a lot of time in city areas. So what we need to do is look at what the rural draw is that gets over that very dry creek bed that we just saw. So we need to have advantage for rural. We need from the country, returning to country. It doesn't mean that people from urban areas don't come to the country. In fact, a large majority of health professionals still come from urban areas. I came from our large capital of Brisbane. So that happens, but my wife was very much, and always has been, a fan of rural settings, and so that certainly made it much more palatable for us. We need community engagement. We need active intervention by policymakers and others. We need role models. We need case managers that will help people get into rural areas. There's one of the programs has a thing called vocational indicative planning, where they work from a very early stage with people who are going into rural practice saying, where do you want to go? How can we make that work? The efficiency and effectiveness advantage comes if we've got integration, continuity, generalism with the breadth, full scope with the depth, enabled and valued practice, transferable skills, and credentialable skills. They need to be recognised so that the doctors are not just seen as the cowboys or those without good skills in rural areas, that the nurses are supported and not left in a situation where they are deemed not to have the right skills to have dealt with a particular circumstance. So we need to advantage rural, and we need to do it quite openly. So we need to have a lovely stream like this, with many people being able to move along that stream to a future career in rural practice. It might be a bumpy one along the way. There might be some difficulties, and we need to, as you can see, they've got some little plastic shields here shielding people from the spray, and we need to do that for our health professionals. We need to have the guidance of the man at the front there with the pole to push the boat around a bit and make sure that it's on track and that everyone is protected reasonably. But it does take a bit of bravery sometimes, both from the steerer and from the people in the boats. They need to trust that the system that's in place will take them down this stream without damage. And it will be then an exciting and memorable experience rather than a difficult experience. I'll be giving you some references, but there's a couple that are important, I think, and this is the WHO guidelines for increasing access to health workers in rural and remote areas through improved retention. It's under review at the moment. It's from 2010. And it mentions many of the things that I've talked about. So that's one reference. I'll bring some others up. But the other two is this one that was led by Roger Strasser, who's been just finished as the founding dean of the Northern Ontario School of Medicine, Canada. And it's called Make It Work, a framework for remote rural workforce stability. And it's got some wonderful things in. It's quite a recent publication. And we've got one of our own that we did with WHO. The Rural Wonka did a project with WHO last year, which is a checklist for implementing rural pathways to train and support health workers in low and middle income countries. We were challenged by WHO to find the evidence in low and middle income countries, and we found it in bucketfuls. So, and there's a number of key areas in this checklist which really look at the same things that I've talked about on the way through this presentation. So I hope that's been useful to you. It's a very quick overview of all the elements that really are required. I'd end up with one thing, and that's that policymakers often want one lever to pull, a magic bullet. They want something they can say, if I do this, it'll all be okay. I think the thing to say to policymakers that I do all the time, and I think all of you who are listening to this need to do, and those of you policymakers need to take heed of this, that this whole stream needs curation from one end to the other. If we put a dam in it, if we divert the stream, if we cause problems along the way anywhere, that stream will not flow. If we stop the water coming in the top end, it will not flow. If we push it all over the banks at the side, it will go into urban. So what we need is curation of the whole stream. We need all the policies that I've talked about, not some of them. And that's my advice to you all. Thank you very much for listening to me.
Thank you, Dr. Chater. It's great to join you and everyone on this virtual conference, although we're all looking forward post-COVID to getting back together to share our interests, our passions for rural practice, and advancing it worldwide face-to-face once again. Just a brief little bit of background. I'm currently the co-chair for the Society of Rural Physicians of Canada Rural Roadmap Implementation Committee, which is a collaborative committee involving our partner College of Family Physicians of Canada and other national organizations trying to move forward rural healthcare in Canada. And yes, it still does need push forward, but we've made great strides over the last 20 to 30 years. I'm going to try to briefly talk today about Canada's rural practice training for the 21st century, our journey along that pathway to develop that, and really focus on the whys and the hows. To put that into a bit of perspective, Canada, as you probably know, is a huge country, 10 million square kilometers, 37 million people only, and spread out over this huge landmass are many rural and remote communities. The remote communities are most often involve Indigenous peoples, and they are often what we consider flying communities where there's no year-round accessible road. But even our other rural communities suffer from isolation, especially because of the severe winter storms that we get. For example, where my wife and I practiced, many winters there'd be 10 or 12 days or even more where you could, because of winter storms, you couldn't get anything in or out, helicopters, planes, ambulances of any sort. So whatever patients you had with their problems, you had to look after. There was no other option to transfer out. Whereas in the summertime, it was an easy 1.5 hour transport out to a larger care center. So that's some of the background for Canada. Some of the other context is Canada has a healthcare system that is provincial with 10 provinces and 3 territories, so every system is a bit different, but it's unified by the Canada Health Act that says that all Canadians should receive publicly supported medical care, and there is no parallel private medical care system. Now, our national healthcare system has some shortcomings. It still doesn't have a national drug plan, although seniors get their drugs paid for, as do most people employed, and as do those income assistance. But the publicly funded healthcare plan is the backbone of our healthcare system in Canada, and that came into place in 1968. Antedating that, and some of the things that moved this forward, is the partnership between the major national organizations, because every province has its own health and education system, own regulatory bodies, so it took national organizations working together to make progress on developing rural pathways. The 2 real pushes for this I want to highlight are the College of Family Physicians of Canada and the Society of Rural Physicians of Canada. Interestingly, the College of Family Physicians of Canada, one of the founding fathers of that and the first executive director was Dr. William Victor Johnson, who practiced just a short way up from where my wife and I practiced. And in 1954, the college was founded by this rural doctor. And at that time, most GPs in Canada, pardon me, did a full generalist practice. They helped mothers deliver the babies. They looked after emergency departments. They looked after patients in hospital, nursing homes, house calls. But by the 1980s, much of the urban family doctors were no longer providing the care for in-hospital patients or maternity care, and they retreated mostly to their offices. These services, like hospital care, emergency medicine, maternity care, were provided by either specialists or doctors with limited practice to those things. And yet, as you well know, in rural practice, there aren't the specialists or others to provide those care. We as rural GPs still need to provide that kind of rural generalist care. So the training was out of sync. So it was a push to training, and that was to help lead to the founding of the Society of Rural Physicians of Canada, which was a collection of rural doctors that really felt the needs were not being met for training the next generation. So they came into force, and by and large, were at first a thorn in the side of the College of Family Physicians of Canada, but helped to push it towards a more aggressive approach to training for rural doctors for Canada. And the College of Family Society of Physicians have been working by and large together to push all the other bodies that are responsible for training healthcare towards a rural training pathways. This included all the medical schools, and so their partnership really got going in the year 2000 with a report that laid out for training for the 21st century for rural practice, which outlined the things that were outlined in the Wonka Working Party Education Rural Practice Policy, which came out in the late 1990s. And those are the things we know are true. Admit people from rural backgrounds, provide undergraduate training for all students, provide specific postgraduate training, and those things, and specific skill sets. And those things have by and large come into place in Canada because of this collaborative push by all parties to make this happen. We now have a widely distributed rural family training pathways for postgraduate training that are in every province, run by every medical school, and that provides training by rural doctors for the next generation of rural doctors in the postgraduate vocational training. We now, at long last, have those identified in the matching services as rural training programs, and we also, at long last, have a set of criteria or skills that people need to learn and called key competencies based on the competency-based approach by the College of Family Physicians for their learning. And so these steps have been a long time coming, but in our widely regulated and yet provincially distinct programs, it needed the national push by the College of Family Physicians, really egged on and working hand in hand with the Society of Rural Physicians Canada to make all the other organizations, medical schools, governments, to support and adopt this big expansion of family medicine and this big expansion of rural training programs. So I see that we've used up our time slot. I'd be happy to answer any more questions. This is all detailed out in the Social Innovations Journal, a case study of Canada's rural practice training 21st century journey. I welcome you to read that and contact me and we can discuss it further. Thank you very much. Bye for now.
Thanks, Jim. I think we're getting some excellent chat, and we'll certainly correspond with you afterwards. We'll get your emails together and send you out some further information as you request. So back to the next one.
Greetings to you all. My name is Farah Noya. I'm a lecturer at the University of Patimura Medical School, Maluku, Indonesia. I'm currently doing my PhD at the University of Western Australia, Perth, Australia. First of all, I would like to thank Nicolas Torres and the committee of WONCATUF Seminar Series 2020 for the opportunity given to me to present a case study under the theme Rural Training Pathways and Pipeline. I would like to present a case study from Patimura University Medical School, Maluku, Indonesia, the island doctors of Maluku. As you can see in the map, that the green group of islands is Maluku in the map of Indonesia. It's an eastern part of Indonesia, which has the most remote, isolated, outer, and poorly served islands. This province has more than 70% of population located in rural and remote areas, and there are one doctor for more than 7,000 people. And National Health Research reports that Maluku province has low achievement in national health indicators, such as maternal mortality rates, infant mortality rates, and rates of infectious diseases. The central government has implemented various policies to attract and bond doctors to come to rural areas in Indonesia, especially as well in Maluku. They provide more incentive and better salary, but this approach is still not effective, given that there are still medical workforce shortage in rural and remote areas in Indonesia. Therefore, Patimura Medical School was established in 2008 with arrangement with Maluku provincial government for financial support. The vision statement of this medical school was to be the educational and development center for the creation of archipelago-oriented doctors of Maluku in 2020. So to achieve this vision, the medical school implemented several strategies. Firstly, student selection with rural backgrounds through a special pathways. So there are bonded places financially funded by district government and bonded scholarship provided to the students from the district. And the other district provides scholarship directly to students from their community that who already passed admission tests and apply for the scholarship individually to the district government. So in this year, we have 10% of the student under special admission pathways. As the impact of the establishment of this medical school with rural vision and mission strategy, since 2015, there were 210 medical doctors who have spread across the Maluku archipelago, and they work as medical interns, temporary medical workers, and civil servant medical workers. For the medical interns, the retention is lower because the short period of internship, which is only 1 year. But for the civil servant medical workers, the retention is higher, even the highest, because the doctor are bonded for more than 5 years, and most of the time it's a lifetime, because a civil servant is a lifetime contract with the government. So this distribution, the recruitment and retention, which already increased, implied that the vision of the Patimura Medical School has been achieved. However, we need to reassess health status of the community where the medical graduates of Patimura University serve. So for further study, to investigate the work satisfaction of medical doctors and their professional development. Also, the assessment of regional and district health status and its association with the increased recruitment and retention of the medical workforce. We hope that the strategies implemented in Patimura University regarding rural training will positively impact the health needs and status of Maluku rural and remote community. This is the end of my presentation. Thank you for your kind attention. And
Thank you very much, Farah, and it's great to see those initiatives happening in Indonesia. I know in Indonesia you have your own Rural Doctors Association now too, which is great to see. Thank you.
Hi, I'm Tamkeen from Jain Medical College, AMU Aligarh, India. This is my working place and this is my team. We all know that India has one of the highest maternal mortality rates. Another problem is that within the country, there is a lot of inequity between different regions. One of the reasons is that we are unable to deliver emergency obstetric care services at the periphery in the rural areas because of lack of trained staff and many other logistic reasons. The WHO has provided a checklist for implementing rural training and supporting healthcare staff in low resource settings. We are providing 2 training programs for these doctors in our department, and all our faculty has been trained for that. One is a 16 weeks training for in-service doctors working at CHCs to provide emergency obstetric care. Another is through our Regional Resource Training Center, which helps in the capacity building of doctors posted at first referral units, and also we provide on-site mentoring to these facilities. We have 3 districts and 11 facilities under our mentoring, and we are paying quarterly visits to these centers and using various teaching learning methods like discussions, demonstrations, videos, etc., as well as providing them 24/7 support through WhatsApp groups and case discussion. How do we know that we are effective? Well, the pre-training and post-training questionnaires, skills assessment through OSCE, their logbook, their post-training mentoring visits, and continuous discussion on WhatsApp groups are some of the methods we use. Let's see what the statistics tell us from the UPTSU. There has been a change in practice. For example, in active management of third stage, now almost 80% of women are receiving oxytocin, and almost 82% are practicing control cord traction. The number of FRUs performing C-sections has increased in the last 3 years from 32 to 52. Considerable progress is there in administration of iron sucrose from 4% to 97%, as well as FRUs are now equipped to perform blood transfusions, as well as the number of referrals has decreased. We have faced a lot of challenges because of the busy work schedule, undergraduate, postgraduate teaching training that we have to do, administrative work. We are trying to do our best. The advent of COVID was a great challenge to us on how to run the program. Well, there was initial some difficulty, but later on we switched over to the online mode, and we have been performing training workshops, assessments, case studies, and even on-site mentoring through the online mode. We have expanded our work, and now we are hand-holding other medical colleges, and we have performed accreditation for a few medical colleges in order that they also become well equipped to train other medical officers. Why do we do it? Well, it feels great when we find out that our trainees have started operationalization of the FRUs, and sometimes they send us Happy Teachers Day cards. But most important for us is that we want to do our bit to prevent the greatest tragedy in medical practice, a preventable maternal death.
Wow. Well, thank you very much to everyone for those presentations, and I hope you've enjoyed tonight. For those of you, it is almost on the hour, and so for those of you who wish to leave, by all means do. I thought we might just keep the conversation open for another 10 minutes or so. Nick, I know the chat that we've got here will be saved, and so we might try and send some of that to you for those who've missed it along the way, or missed some of the links. But I think just fabulous presentations from our case studies. So I'll just open up. You can unmute your microphone for those who'd like to speak. If anyone's got any particular questions of our presenters, as I said, we'll go for 10 minutes, but by all means, feel free to leave. But I'll just open up. Has anyone got any particular questions that they'd like to talk about either from the chat, from the case studies, or from my lecture. Anyone got any comments?
It's Jim here, Jim Rourke.
Yes. Go ahead, Jim.
I think we've found the two biggest advances were the longitudinal integrated clerkship, where students spend 6 months to a year in a rural community where they really develop a understanding connects rural communities that really seem to stick like glue. And then the other thing we found at the postgraduate level was, instead of having the trainees go to a bunch of different rural communities to see what was the best of each one, having them live with their living circumstances in a rural community for the better part of their rural vocational training and come back to the cities for their city experience that they need to do some high volume things was so important. And that what happened was then they'd make friends, maybe meet a spouse for that 2 or 3 years in the rural, 1 or 2 or 3 years in the rural community, and that became their home and their natural step into that or a similar community for practice. And that made a fundamental difference at that critical last point of training.
Thanks, Jim. Anyone else got comments? Just that flipped bit I've just put in there that we call it live in, drive out. So you live in the country and drive out to what you need to do, rather than living in the city and driving in or flying into the rural areas. Ewan McPhee's just sent an apology. He's got a storm over his area there, and his satellite has become obscured. But he did ask, would this recording be available? And yes, it will be available, both through Towards Unity for Health and through Rural Wonka. And I noticed Nick's just also confirmed that the chat will be available, and we'll send the chat out to this group who've been on this, just so that you can revise back through that if you'd like to. Other comments?
That's Jim here. I'll throw another one in. One of the critical factors we found that loses rural doctors is, in rural practice, you have to do things that sometimes are way beyond what you've had in training or skill set. There's no way else to do it. And things don't always go right, or sometimes you have to transfer somebody and you can't get out and you're dealing with this horrendous case. And if those doctors don't get the support they need, then they can often find, oh God, that's enough, I'm out of there. And there's critical points in people's career where support from colleagues and the system is so vital to be there. And we need to make sure that we support our rural doctors who are having some troubles or challenges, because a bit of supportive intervention can make a career difference, and they hit that fork in the road and they decide to stay or go.
Thanks, Jim. I just, it brings to mind an interesting piece of research that I can send around on clinical bravery that was done by a number of doctors, many of whom are involved in the Rural Wonka, worked on the Wonka Working Party. And in fact, there's a study at the moment around clinical bravery in COVID-19 circumstances. So, and by that, well, you could read the paper, it defines it, I think, particularly well. But it's often the rural doctor who the people who survive in rural practice are those that embrace that, but still manage their risk particularly well, so that they have the ability to step up and do things, but still be safe in that environment. So, so Marjorie's just asked about how support materializes, and I think that's one of the things is trying to build a good team that can provide the support and trying to get the right culture. And at Marjorie, it is a pushing uphill sometimes to do that, particularly with some of the attitude of bureaucracies at times. Anyone else got any comments that they'd like to make?
I'd go back to Marjorie's comment as well. What we've also found is that rural doctors can feel pretty isolated with psychological stresses or that. They don't want to go to their local priest or minister or social worker for counseling. And our medical associations have in the last few years really stepped up the confidential counseling lines where doctors anywhere can call in for counseling, help with a crisis, whatever it is. And again, it's not like in the city, you can just walk around the corner to find a counselor. These things can be, again, career savings. And I think, so it's not just governments, medical associations themselves can be involved in supporting the members. And of course, as colleagues, we all want to support our people, but sometimes people need that confidential support too. Not just for doctors, that's a great idea.
Yeah. I noticed Matt Maisel on, and I don't want to dump him into this, and maybe he might not be able to talk about this, but Matt's been a champion, and so has his wife, been champions of the Rural Doctors Association in Queensland, and I think we've seen a flourishing of those organisations, Society of Rural Physicians of Canada, the Rural Doctors Association now in Indonesia, as I mentioned before. The very first Rural Doctors Association was in Norway. Those organisations provide wonderful collegiate support, and I certainly wouldn't have survived as well in my practice in rural areas if it hadn't been for that collegiate support. I wonder, Matt, did you want to say anything, or anyone else from Norway or elsewhere want to talk about the role of those collegiate supports? Nope. I think it certainly makes a big difference. Certainly makes a big difference.
Bruce, I want to again have a bit of a conversation. We pick up on the importance of having a society of rural physicians or a organization of rural doctors like you have in Australia, ACRM, and that although they've been varying levels in different countries, without that, the major organizations don't have the push to make a rural a focus. And I think it's essential that there's a rural doctors organization, even if it doesn't go as far as Australia, where you've organized your whole training program, but every country needs one to push the other actors and the people who control the levers of power to actually make change to support rural. Without that, we're not getting anywhere. So the doctors working together, the rural doctors working together in some organization is essential to move things forward.
Thanks, Jim. And I think it's those role models. Marjorie was talking before about the lack of support in primary care in Australia, and I think there has been a broad lack of support, but there's a clear need for advocacy about rural practice, and that can be seen by some people sometimes as a bit elitist, if you like, saying rural practice is excellent practice. But that's what we need it to be. We need to have that ability to push people in that direction and make it something that's a really terrific career to be in. We've got just a few contacts. So I think there's some wonderful stuff coming through on this chat, and I'd be, as I said, maybe in these last couple of minutes, just talk about how we're taking this forward. I would hope that we've got about 39 of you on the teleconference tonight. We'll look at linking you together a bit around this topic. I think there's been, as I said, some great chat and great discussions. We want to take each of these sessions, there'll be one each week approximately, through to our closing ceremony. And we're hoping both to make sure that Zakur has a wonderful statement at the end that will support the people of Bangladesh. We, with our conferences, have very much always focused on leaving good things behind for the people who organise the conference. So we hope that Zakur will be able to leverage with this to get more medical students in rural places, more doctors in rural places. So we're hoping to move to that closing ceremony. Nick's showing the details there. The closing ceremony is on the 21st of February. Have a statement there, but also increase the discussion, particularly between our two organisations of Rural Wonka and Network Towards Unity for Health. So I won't hold us up any longer. It is 10 minutes past, and I did say we'd just do the 10 minutes past. Zakur's out there with his mask on in the back of a tuk-tuk or whatever by the look of things. I might just ask Nick for a closing comment, and then I'll leave Zakur to do the last comment from behind the mask. Nick?
Thanks everyone for joining. And again, I think as Bruce said, this is just the first of many, and you know the network will grow. But thanks Bruce for doing all this, and I'll turn it over to Zakur.
Okay, Zakur, you can close the discussion for the night. Over to you.
Okay. Bye, Bruce.
Okay, thank you, and we'll look forward to seeing you in the next few weeks. Thank you for your participation. Thank you for the chat, and thank you for your interest in this discussion. Thank you all. Night night.